ACE. To save our time, because I know I have only 5 minutes to do this, permit me to welcome everybody who is here today, and let me go with the address. It is my pleasure to welcome everyone to the second day of this deliberation on the health sector. Yesterday, the House of Representatives engaged with experts and critical stakeholders of the sector, from local and international organizations, on the issue of reprioritizing on health in the context of the Abuja Declaration. The House also discussed building a resilient system, lessons from the COVID-19 pandemic. We had very insightful feedback and recommendations from renowned experts like Dr. Chikwe, who displayed a huge intelligence and approach to the work he has been doing for Nigeria. He's the Director General of the NCDC. Also, listening to Dr. Walter Kazadi Molombo was such a delight. He's the WHO country representative to Nigeria. Dr. Ibrahim Wada, who is also well celebrated, the CEO of NISA Premier Hospital. Dr. Gafa Alawode of Lisdell. Professor Kevin Chika Orama of African Development and HIV for UNICEF. Dr. Hadiza Kamufu, Country Director of FHI 360, and Dr. John Adedoyin of MSH. The lessons and recommendations made are instructive, not just to the committees on health services and health institutions, but to the entire House of Representatives. A key takeaway from yesterday's section was the need for a reassessment of the priorities in Nigeria's fund allocations within the health sector. The government must prioritize capital expenditure over recurrent expenditure and primary health care over specialized health care. This feedback will guide the legislature's approach to appropriations and budgetary approval, knowing fully well that that is what we are faced with at the moment. We are thankful to Dr. Walter Molombo for emphasizing this. He really did yesterday. There were several other lessons learned from our engagement yesterday. Dr. Ibrahim Wada made a convincing case for public-private partnership as a creative approach to improving healthcare financing. Dr. Chikwe Nyekwazo and Dr. Kamufu reinforced the need for a robust national healthcare management information system, a gap that is existing in our system and in our country now that need to be filled. While I cannot go into the details of all the yesterday's recommendation for want of time, I must state again that at the end of this roundtable, all deliberations and recommendations will be reproduced in a document we have called the Green Book, like I mentioned yesterday. This will be presented to the leadership of the House to serve as a guide in our legislative interventions in the relevant sectors. Interactions which each sector shall be sustained through various technical sections between the relevant legislative committees, in the case that we are handling now, the House Committee on Health Services and Institutions, and key sectorial stakeholders who will, with the support of the AIDS Center, participate in the development of bills, motions, and measurable indicators for oversight activities. Before I conclude, I must compliment our moderator once more, Dr. Nkem of Preston Development Foundation, for her style, which has leveraged her health policy experience to elicit productive discourse. I must also appreciate the co-moderator, Dr. Chioma Nwakanma of SMILE, for Me Foundation, whose zest and charisma has driven our interactive section so far. I thank our panelists and all the stakeholders who have tuned into the conversations, scheduled for today, as we discuss the very important issue of capital flight and brain drain in the health sector and universal coverage from health insurance and tax-based financing. We must see a departure from the practice of legislating and policy making without proper stakeholder consultation or evidence-based premises. This is what the Media and Public Affairs Committee of the House seeks to achieve through this sectorial engagement. Again, I encourage other sectors to brace for engagement with the House, and I seize this opportunity to call on CSOs and other development partners to join the House in this endeavor to promote transparency, accountability, citizens' participation in governance, and to strengthen our democratic institution. I wish everyone a fruitful deliberation. Thank you very much, and I hope to enjoy the interactions from now on. God bless.
Thank you very much, Honorable Kal. That was amazing. It showed that you were listening. I'm so happy that the East Centers put this together and that the Federal House of Representatives is truly engaged to hear what the population has to say. So thank you very much. Now we move to the keynote address that will be given to us by the representative of Honorable Dr. Pascal Obi. I think Honorable Dr. Martin from the House Committee on You, sir. You're very welcome to the panel, and we look forward to hearing your keynote address. Thank you.
Yeah, thank you, Moderator. I'll first of all thank the House and welcome them to this session. And in a special way, I must appreciate the chairman of the House Committee on Media, Honorable Benjamin Carlo, and the Honorable Minister of State for Health, Senator Mamora, and all the participants in the House. Thank you so much. I'm making this presentation on behalf of the chairman of the House Committee on Health Institutions, Dr. Pascal Chigozie Obi, who is out of Abuja. I myself as the Deputy Chairman of the House Committee on Health Institutions. So I present this, but before I present this, what we're handling today is brain drain. Yes, and we're going to speak particularly on tackling the brain drain challenges, accessibility of healthcare using the primary healthcare center as a model. But I want to share this experience on brain drain. I graduated from one of the medical schools, from University of Nigeria College of Medicine in the 80s. And at the point of graduation, we're about 150 that graduated. Just last week, one of us opened a platform for us to interact. And we noticed that out of the 150 that graduated in the mid-80s, that about 120 outside the country. That's a very dangerous disease. So when I was told to come and make this presentation, I said, I will share this. I will tell you, and I'm sure other people have their own experiences with a number of Nigerians who are outside the country, serving different nationalities. And before I finally present this, there are some of them already, one is the issue of economy. But by the time we graduated, that was when the Nigerian economy collapsed. And most people had to leave Nigeria. But the economy is one thing. But the second one is that when people reach a certain degree, the job satisfaction becomes a major driving force. They reach a point where they are very comfortable. But they cannot just practice the kind of infrastructure you have in Nigeria. So when you tell them to come back, they will come back. My first cousin is an obstetrician in the US. they acquired land for him to build also to do a lot of things. By the time he came back, he found out that he just couldn't practice within this place, and he had to go back to the United States. So one is money, economy, people looking for this in which they have a right to aspire to. The second one is job satisfaction, the practice, the facilities, the debt of infrastructure in the health sector. That is one of the major things driving people out. These are some of the things that are driving people out of the country. So let me go. I just say I should share this personal experience. Let me now go ahead and present the speech on behalf of the chairman of the Health Institution Committee and on behalf of the committee. Yeah, the first session of this, my delivery is tackling capital flight and brain drain in the health sector in Nigeria. Nigeria is obviously the most affluent Black nation in the world and has some of the most skilled and educated men and women you can ever imagine. However, Nigeria also has a large population of adults who are seeking greener pastures based on the reality of the situation of the Nigerian economy. This is why we are gathered here today to discuss how to make Nigeria health sector work. All over the world, the brain drain phenomenon has attracted and drained many Nigerians, educationists, technocrats, scientists, doctors, artists, to mention but a few. The term brain drain was first used in the early 50s to describe the outflow of scientists, engineers, physicians, technologists, and other professionals from developing countries like Nigeria to the United States, to Canada, and other parts of the world. In the 19th and the 20th centuries, there were great migrations to North America and other parts of the and to Europe. The medical field is one of the areas that are hardest hit by the brain drain phenomenon. In Nigeria, it's been recorded that 5,405 Nigerian trained doctors and nurses are currently working in UK, the National Health Insurance Scheme in the UK. The figure, which was recently released by the British government, showed that Nigeria medical personnel constitute 3.9% of the 137,000 foreign staff out of the 202 nationalities working alongside the British doctors and nurses in the United Kingdom. The cost of human capital flight has been discussed at different fora with a consensus opinion that it has its merits and demerits to equitable health system. Every year, thousands of qualified doctors and other professionals in the health sector in Nigeria leave Nigeria tempted by significant higher wages, brighter process of employment, education, stability, and food security. To buttress the significance of brain drain, Okunubi 2013 posited that the United States Diversity Immigration Visa Lottery makes up to 55,000 diversity visas available annually to countries with low risk of immigration in the United States. Out of this figure, Nigeria has the highest number of entries yearly. In the meantime, the physicians to patient ratio in Nigeria has dipped further down from 1 to 4,000 patients to 1 to 5,000 patients. This is very, very far from the World Health Organization recommendation of 1 to 600 people. How does the country begin to address the problematic high capital flight from the country? One of the ways is to dramatically raise the level of investment in education and health. This is where we will start to build a progressive society and an environment that is conducive to human capital, for human capital to function maximally. The immigration surge in the 80s was driven by the foreign investment in the closely interlinked sectors. If foreign government revenue induced lower investment, such where government will have normalized it. The experience from the developed countries is that raising investment in human capital causes fertility rate to reduce. Nigeria is currently producing more than enough children than it can cater. According to data from the UNICEF, Nigeria accounted for a third of newborns in January 2018. A great percentage of children will probably join the already 13 million out-of-school children when they grow up or grow older, as the actual per capita spent on education and health continues to drop in the country. However, the question arises, where would the funding for the human capital investment come from in the constricted fiscal space? We have to look for the short and then to look at the long-term solutions. In this short term, government has to restructure public expenditure by cutting wasteful spending and reducing the number of political appointees. Government at the federal and state levels can free up more money for investment in education and healthcare. This measure will help optimize the impact of the new fiscal strategy of the federal government that seeks to reduce its stakes in the joint ventures with the multinational companies. The revenue gained from this asset sale is one-off, but its use should make long-lasting economic impact. In the medium to long term, government needs to deliver on the structural transformation of the economy. The value chain of multiple sectors, including oil, gas, agriculture, solid minerals, and tourism, have to be developed. This is the practical way to deliver on the much talked about diversification of the economy. In that scenario, the SME sector will begin to help raise national productivity, create employment, reduce poverty, generate more tax revenue. The space for Nigerian talents to express themselves in the local economy will increase. The increased opportunities that this will generate in the private sector will be a boom for Nigerian professionals, entrepreneurs, and then the entire workforce. This is the first section of this presentation. The second one is talking on universal health coverage, that the primary health care centers as a solution to accessible health care. 3 decades after the 1978 Health for All Declaration in Almaty, Russia, then the Soviet Union, the World Health Organization has called for a review focus on healthcare with the launch of the 2008 World Health Report. When countries sought guidance on financing healthcare, World Health Organization commissioned a 2010 report on universal health coverage, a concept then pioneered as central to sustainable development goals and the ambition to leave no one behind. In 2008, World Health Organization wrote the World Health Report, which gave a realistic appraisal of the status of primary health care in the world. In all 6 World Health Organization regions of the world, it was unanimously agreed for a return to the principles and approaches of primary health care as the best way to organize health services. In 2008, when the World Health Report on primary health care, now more than ever, was published to mark the 30th anniversary of the declaration, it critically assessed the way the healthcare was organized, financed, and delivered in rich and poor countries alike. And found striking inequalities in access to healthcare, health outcomes, and what people have to pay for care. A revitalization of primary health care was put forward as the best and most affordable way to get health systems back on track. When countries at the same level of economic development were compared, those with health care organized around the tenets for primary health care produced a higher level of health for the same investment.
Yes.
In the largest sense, the report was a call again, put health equality on the international political agenda. A move towards universal health coverage was promoted as the core strategy for tackling inequalities. Way forward, making a case for primary health care as a solution to accessible care. A leading American economist, Jeffrey Sachs, Emeritus Professor of Economics at the University of Columbia, made a strong case for abolishing user fees and making primary health care accessible to all by using the primary health care centers as a platform. Sachs argued against the lazy thinking that continued to justify user fees as a protection against the overuse of health services. As he noted, for the very poor, no price is affordable. Even nominal user fee can lead to massive exclusion of the poor from life-saving health services.
Yes, sir.
Significant progress against malaria began only when World Health Organization policy called for the massive free distribution of insecticides and nets.
Thank you, sir.
Again, Nobel laureate Amartya Sen explained why universal health coverage was an affordable dream, even for very poor countries. As he observed, many poor countries have shown that basic health care for all can be provided at a remarkably good level at very low cost if society, including its political and intellectual leadership, shows high level of commitment. In September 2015, in the eve of the United Nations General Assembly that would adopt the 2030 Agenda for Sustainable Development, leading economists from 44 countries called on the global policymakers to prioritize a pro-poor pathway to universal health coverage as an essential pillar of development. As they noted, health systems oriented towards the universal health coverage immensely vulnerable in their own right, produce an array of benefits in times of crisis. They mitigate the effect of shocks on communities. In times of calm, they foster more cohesive societies and productive economies. Finally, the conclusion of a target for universal health coverage in the 2030 Agenda for Sustainable Development Goals has ensured that universal health coverage will be a strong agenda in the health policies of all countries in the world, Nigeria inclusive. In Nigeria, there is need to ensure primary health care is well and that the primary health centers are functional with the provision fund and stakeholders like the women private sector to be formed for the much needed universal health coverage that every Nigerian dish of all greatly deserves. Thank you so much.
Thank you very much, sir. That was very informative. I totally agree with you. I think the three aspects that you really dwelt on was how to expand the pie by looking at sectors that haven't received too much attention so far. You talked about many of our natural resources that need to be optimized. And then you talked about being, managing better what we already structural adjustments are allocated. And then finally, the way we spend. I mean, it's one thing to have a big pie, but if you're eating it at a rate that is unsustainable, you won't have anything left. So looking at reducing the size of government, I thought that was radical for somebody in government. Thank you very much for your candor. I appreciate your transparency. Thank you very much. Okay, so next on the agenda, we have the Honorable Minister. So we will move on to Professor Innocent Ujah, who is the President of Nigerian Medical Association. And congratulations on your election, sir. and you're very welcome to the panel, and we can't wait to hear your presentation about the brain drain and captive flights in Nigeria. Thank you.
Well, thank you very much, and I want to appreciate the organizers and the excellent work done by Jacqueline, who had been in constant contact with me, and for her, it would have been impossible for me to participate in this because I've been moving a lot. But this is a very important issue. If we have to develop, we must have a health system in place. So I'll be discussing very briefly the capital flight and brain drain in the health sector. Well, I'm not sure if he's going to present this. I will give a brief introduction issue of the on ground in the health sector, forms of capital flight in Nigeria, and brain drain, some other factors. Am I being heard?
Yes, absolutely.
Now, yeah, fine. Capital flight is a persistent and disturbing macroeconomic issue with implications for growth and development of countries, particularly in developing countries like Nigeria. And we cannot overemphasize that statement. And capital flight can be defined as the outflow of resident capital or financial assets from a country, which is motivated by economic and or political reasons. It inhibits economic development and growth from the countries of origin, and most especially, very good, and most especially developing nations of the world. We all know the deplorable health situation in Nigeria, and I don't want us, can we move forward to slide 4? We are very conversant with the deplorable situation of our health situation. We keep on making statements on this. I'm happy that Honorable Martins had given a very lucid presentation on that. I don't want to go further on that. The National Assembly should tell us where health is really in the Constitution. Is it on the exclusive list? Is it on the concurrent list? Or is nowhere? Because it depends on who is saying what. We don't know where we are in health. In contradiction with the law. So we are neither here or there, and I think that we need to look at that. We all know that we have a very deplorable health system, and it is not out of place to state clearly that the indices of development, I can just give 2. One is maternal mortality ratio. First of all, let me state that I'm a gynecologist, and the issue of maternal mortality ratio is so deplorable and shamefully so for Nigeria, and also infant mortality. It is quite high. And it varies from geography, from region to region, from zone to zone. So it's as bad as that. And we cannot overemphasize the deplorable situation. The life expectancy, again, it depends on where you are. Where probably we in the Southwest and Lagos, you find probably that the lifespan is higher than when you come to the North, which has terrible health indices, include, unfortunately, Ebonyi in the Southeast is like the North when it comes to health, very poor health indices. Unfortunately, despite our persistent calls to the executive and to the National Assembly, improve the budgetary allocation to health, it falls on deaf ears. And we don't know what to do again. Maybe the National Assembly, some of our colleagues in the National Assembly will advise us how best to approach this. We've done all that we needed to do, we believe, to improve the budgetary allocation. And it's not just budgetary allocation. You allocate, how much do you release? And what is it, how do we monitor the utilization? These things are not there. As a DG of NIMA, I know that the budget for the Nigerian Institute of Medical Research annually had never exceeded 45% the release, even when the amount is very paltry. So I can say with authority that we really do not have, we don't give priority, we don't invest in health sufficiently compared to our GDP and even to our population. It is not, it's saying the obvious to say that the out-pocket expenses in Nigeria is so high for health, despite the fact that we have the National Health Insurance Scheme, which obviously has been stunted in growth and performance, and we need to do something about this. I would say upfront that one of the answers is to ensure that every adult Nigerian is enrolled as far as health insurance is concerned. We will not get what we believe is adequate from government because of the competing needs as well. Now, the way effect, you all see what we face this year, the unexpected invasion of COVID-19. It exposed the weakness, the unpreparedness of Nigeria in terms of and response. We are really not doing well in that regard. So it exposes our weak health system to do something about that very quickly, because it's less overlooked. We overlooked the effect of in 2014. We must not allow this to slip us by. Now, capital flights, and one is brain drain, and that was medicines that we because of time. Now, the monetary capital flight in the health sector is medical tourism, and we all know, in fact, it describes organized travel outside the country's outside one's natural healthcare jurisdiction for the enhancement or restoration of the individual health through medical intervention. The reality is that in the 80s, in the 70s, Nigeria was doing very well, and India was doing very poorly, but they went into self-examination and found that there are ways. And today, Nigerians are trooping into India as if the thing is that all their hospitals there are private sector driven. They're not government. And we can do that in this country. But for, in Nigeria, everybody knows everything. Even those who have no modicum of ideas as to how a hospital should be set up will say many things that will not even be positive for our health. And I must say too that even at this $1 million the CBN had allocated to health, no medical doctor has been able to access it. Why? Why is that so? And the money is gone. We are told this is for the health sector. The doctor is the leader of the health team and is not in doubt. But how come even when they met all the Association of General Medical Practitioners had met with me, and they're having challenges of accessing that fund in CBN. So the National Assembly should please come to our aid in this regard, because we keep on talking and no action. It's like motion without movement. Now, the cost of tourism, I've talked about India. In 2012 alone, Nigeria spent over 260 billion US dollars on medical bills in India. It's clearly established. 40% of all visas to India were for medical tourism. And there's no reason for India to be better than us. We have a very intelligent health workforce in this country. What we don't have is the weak system that Honorable Martins had said, and the lack of commitment of our leaders. That is the truth of the matter. We do not give priority to health. Health is a very, very heavy investment, and we should please look at that. I'm not talking of other major tourism destinations like the United Kingdom, Turkey, South Africa, Saudi Arabia, and so you find that Nigerians' foreign exchange is depleted largely from medical tourism. Now, what are the implications of medical tourism on our economy and the health system? First, the capital flight leads to weak economy. That is true. We talked about the amount of money, and what we are saying may be more than this. Now, we have the weak health system with poor outcomes. Of course, brain drain, poor funding, poor investment in the health system, poor infrastructure. And when we talk of poor infrastructure, Honorable Martins had said this, the infrastructure is so bad that we should not be talking about it. Is it road? Is it light? Is it water? When I was in Nkem, we did a quick survey of all state capitals in this country where water should run for 24 hours. And we did not have any, including Abuja, except if you are in Metama or in Nasarok. So we need to improve the infrastructure. And this has been compounded further by the insecurity in this country. There's no doubt about that. The issue of Boko Haram, the issue of kidnapping, the issue of monumental robbery, armed robbery. Those are some of the things that drive our people away.
Sir, Professor Ujah, please, can I crave your indulgence to just interject here a little? The Honorable Ministers of State for Health have just joined us. Dr. Adeleke Mamora would like to welcome you to the forum. We look forward to yours after Professor Ujah has finished. Prof, in the interest of time, we're trying to keep some time for the interactive session. So if you could please somehow summarize what you have.
If you actually delay me, because I was going to have finished. Let me welcome my Honorable Minister, who is very passionate about health. The reality is that we need, let's go to the solutions. Let's go to the solutions. Now, in our own way, we believe that we can solve some of our problems. We would not want to talk about the consequences because we all know the consequences. But what is the way forward? The way forward is to improve healthcare financing. And this is very important. We need to improve healthcare financing. I know that in last year, the participants in NIPS had healthcare financing as their major topic. And I believe that probably is gathering dust somewhere because it's not, nobody looks at what is done in NIPS, and they should do it. They should get the documents and their recommendations. Full implementation of the National Health, at this moment, the National Health Act implementation is neither here or there. It's very poor. Increased coverage for social health insurance. And we talked about this, that every adult Nigerian should pay for health, even if it is 500 naira every month. That will improve. Improvement infrastructure, light, water, roads, we talked about it, and we talked about equipment and supplies in the facility, in the hospitals. Now, one of the areas that I want to talk about is the establishment of a bank for health. We need to have a bank for health. If we can have bank for industry and bank for agriculture, why would we not have bank for health? So that private practitioners would then get, and we have consortium that will be built in strategic areas of Lagos, Abuja, Port Harcourt, Kano, and the rest. I mean, in specialized areas, just like they do in India. If we do that, we will not have any reason to go abroad because our Nigerian doctors and other health workers are very well trained. And if we do that, we will get a lot, and then we'll stop all this medical tourism. Finally, I think that we should look at the public-private partnership. It's very important. We cannot run away from it. Wherever there is, we find that things work very well. Governance is important. Sustained political commitment is important. And we look at this, you see, we quote figures from other places. We don't accord research, health research, any priority in Nigeria. For us to be able to monitor, evaluate whatever we do, research is a factor, very important factor. And I'm happy that the Honorable Minister of State for Health is there. We've been talking about it for a very long time. We need to improve the welfare of doctors and other health workers, upgrade hospital facilities, increase healthcare funding, improving working conditions. The environment where we work is very, very, very bad. It's very harsh. So in conclusion, capital flight is a persistent and disturbing economic problem in Nigeria and affects growth and development in every sector, including the health sector. The poor and weak state of our health system must be looked at. We have been talking about it, but no action. Poor fundings and political commitment, we talked about that, and we will be saying that the fact is that health workers must be motivated. They are not like every other sector. They must be motivated to continue to do their work. Motivation is not about money alone. Motivation, equipment, facilities, environment, safety is important. Finally, we must have health research as a priority. Thank you very much.
Thank you very much, Prof. I mean, this is clearly from the perspective of the practitioner. And we really took to marshal all these points together. Of particular interest is, the fact that government cannot do this alone. The public-private partnership is something that we really should look in your reference to the amount of money that is leaving the country to India, where the private sector is the recipient of that money, not the government. So it's interesting that we have the potential to build our private sector to command that kind of power in terms of being able to attract funding. The other thing is the investment in infrastructure. Hospitals alone cannot do it. We don't have water, we don't have light, and we don't have roads leading to the place or ambulance for the ambulance to get the people to the hospital. So that's also important. And then finally, what you said about establishing a national health bank for health. I thought that was interesting. I don't think anybody's said that, but I think it's something that is definitely worth looking at. So thank you very much, Prof, for your contribution.
Thank you.
Now we will move to the
Before you go there, can I be
excused? You're very welcome to this forum, and we look forward to your presentation. Go ahead, sir.
I'll go now.
Oh, thank you very much.
Okay. Yes, sir. That's fine.
All right. Well, distinguished colleagues and participants on this platform, please just accept my apology for appearing late. Appearing late, not because I wanted it that way, but some technology issues along the line. I want to thank the organizers for making me part of this engagement on this platform, and particularly talking about capital flight and brain drain. And these are two very important issues that give us concern, not just in the Federal Ministry of Health, but also the government of Nigeria. I can assure you is also worried about these two issues, capital flight and brain drain. These two, they have impacted negatively in terms of our health, but even in terms of the economy of the country. And they have impeded the health system strengthening efforts of the government and limited all efforts towards achieving a resilient health system. Medical tourism is a major driver of capital flight, with far-reaching economic and health system implications. Reports have estimated capital flight to be over $1 billion annually for medical tourism. And these are resources which will have further advanced our health system if utilized efficiently domestically. And almost 60% of these resources were spent mainly on 4 key specialties: oncology, orthopedics, nephrology, and cardiology. And several reasons have been given to justify medical tourism, such as cost for specialized care for certain ailments and absence or inadequacy of some advanced diagnostic and therapeutic techniques in Nigeria. Although some of the reasons for capital through medical tourism are germane, they have implications for health equity, whilst contributing to slowing down the progress towards achieving universal health coverage. The Federal Ministry of Health has made significant efforts aimed at stemming the tide of capital flight from medical tourism. Yet, progress towards reducing medical tourism in Nigeria remains slow. The healthcare service delivery system is currently being reformed to ensure that it is more robust and aligned with the health needs of the populace, with special focus on specific disease areas for Nigerians who may want to travel abroad. The government is increasing its investment into the health sector, with most of our tertiary healthcare facilities across the country being equipped with state-of-the-art infrastructure, and quite a number of them through PPP arrangements to enable them to provide world-class healthcare services. And some of the equipments include ultramodern radiotherapy machines for cancer patients, as well as high-resolution CAT scan and MRI machines, among others. Additionally, the government has supported the healthcare workforce to acquire advanced skills through professional training programs within and outside Nigeria to enable them perform specialized procedures and provide quality services. Our ultramodern infrastructure, combined with expertise of the health workforce, has led to the successful conduct of specialized procedures in Nigeria. And I can tell you that this year alone, the National Hospital Abuja, Federal Medical Center Yola, Federal Medical Center Kefi, they have all successfully separated conjoined twins, while several tertiary facilities can and have successfully performed kidney transplants, as well as advanced cardiothoracic, neurospinal, and orthopedic surgeries. These successes are on the track to increase as the Federal Ministry of Health continues to support the establishment of specialist facilities for orthopedics, ophthalmologic, and psychiatric, as well as cardiothoracic and neurospinal care across the country. Further to the efforts of reducing capital flight from medical tourism, private sector currently has been leveraged to complement government's investments in the health sector. And several private sector actors independently provide specialist care for disease conditions that would otherwise have been treated abroad, while public-private partnership arrangements are gradually contributing to improving healthcare delivery service across Nigeria. The Executive Order Number 1, which increases the ease of doing business in Nigeria, and the recent removal of import duties for medical and pharmaceutical products and supplies, they are testament to government's commitment to encouraging private sector investment in the health sector. And these efforts will be continually intensified to ensure a drastic reduction and eventual elimination of capital flight from medical tourism in Nigeria. Brain drain of the healthcare workforce, another major challenge that has plagued the Nigerian health system for over 3 decades, with over 337,000 Nigerian doctors practicing around the world. The United States, the United Kingdom, Europe, Australia, and Saudi Arabia are some of the leading destinations for Nigeria trained health care workers. While the WHO recommends a doctor-patient ratio of 1 to 600 patients, the recent National Health Workforce profile published by the Federal Ministry of Health estimates the doctor-patient ratio in Nigeria to be at 1 doctor to 2,753. So brain drain continues to worsen the gap in human resources in Nigeria health system. And the depth and swiftness of migration has made the task of bridging this gap more difficult. It has had profound negative implications for the economy and the health system in general. The government of Nigeria has always invested significantly in medical education, making Nigeria one of the few countries where medical education and training is largely affordable. While the government has ensured that medical education is significantly subsidized to ensure an increased turnover of health care workers needed to fill the human resource gaps within the health system, it is rather disheartening that a significant proportion of this indigenously trained health care workforce are exported to other countries to strengthen their health systems, leaving Nigeria's health system to grapple with serious human resource challenges. So what I'm saying here is that we train our doctors here and other health workers only for them to take off and strengthen the health system of course, the countries that they go to. So the quest for higher remuneration and ultra-modern facilities has been posited to justify the worrisome trend of increased exit of our health workers to other climes. The Federal Ministry of Health is working assiduously to minimize the proportion of the health workforce that leaves Nigeria in search of opportunities, in addition to increasing the retention of health workers towards bridging the gap in human resources within our health system. And some of these efforts recently culminated in the passage of the Medical Residency Training Act of 2017, which is designed to provide a template for better postgraduate training for other healthcare workers, such as nurses, pharmacists, medical laboratory scientists, have also been encouraged to embark on graduate medical education programs to increase their professional competence in their respective postgraduate colleges. Efforts have also been made to enhance retention of health workers, and this includes increasing the remuneration of the health workforce, providing more career advancement opportunities for healthcare workers, and improving the working environment and infrastructural facilities within the health system. Yes, and I'm sure Professor Ujah alluded to that, because a lot of times what happens in the health sector, they are not necessarily direct issues within the health sector, but they are like other things that need to be in place. For example, water supply is something that should be taken for granted, but in reality, it's not that way. The same thing goes for electricity supply, power, which is critical, for the efficient functioning of the. Recognizing the role of professional bickering and disharmony, the government has intensified efforts aimed at fostering harmony and reducing incessant strikes by health workers in Nigeria. Of course, professional rivalry is one of the major issues too that we contend with. And I am one who persistently and consistently reminds all of us that health care is a team event. It is not a solo event. And so everyone has to be on board and everyone recognizing the role and the importance of each member of that team, so that collectively we can deliver to our people. Government has also moved swiftly to increase the number of medical training institutions across the country. Another key strategy is the adoption and promotion of task shifting within the health workforce to increase health system efficiency. Additionally, the federal government has reached out to the Nigerian health workforce in the diaspora to develop framework which enables them to periodically return to provide training for health workers in Nigeria based on their expertise in a bid to support delivery of healthcare services to the populace. Although government has made concerted efforts and is still committed to actively engaging in discussions while developing and implementing feasible and long goals, more needs to be done, I must say. For Nigeria to effectively tackle the challenges of brain drain and capital flight from medical tourism, a multi-sectoral approach is required, with substantial increase in the resources allocated to the health sector. And I know that Professor Ujah mentioned this. For me, you see, I have always believed that one of the things we need to do, and very, very urgently too, is to have what I call shared national vision. We must sit down together and agree that health, we cannot be mouthing that health is wealth. We say health is wealth, but we are not according health its rightful place.
Yes, sir.
And we know that in human capital development, two sectors are key: health and education. So that is why we need to agree. You see, all animals are equal, but some are more equal. We cannot treat health just like other sectors. For as long as we continue to do that, we will be deceiving ourselves in terms of wanting to improve and getting things right in the health sector. So we must agree, and therefore collective agreement. That's why I call it nationally shared vision, so that we allocate and then give the health sector its pride of place. All stakeholders in the country have a role to play in this regard, and collective efforts will significantly advance government's goal at minimizing brain drain and medical tourism. The Nigerian National Assembly has a critical role to play to support the efforts of the Federal Minister of Health in advocating for increased domestic resource mobilization for the health sector, in addition to playing their oversight role to foster efficiency in administering the funds for impactful interventions. Of course, the private sector actors are also pivotal in the entire architecture and supporting government efforts. It is most expedient that they lend their support to ongoing government efforts in much healthcare services and providing benefiting remuneration and working environment for the health sector. The government of Nigeria is curbing brain drain and medical tourism through strengthening strategies, while reaffirming its commitment to the attainment of universal health coverage. Distinguished ladies and gentlemen, I appreciate you all for your audience and express my profound gratitude to a wealthy and economically prosperous nation. Hence, all hands must be on deck to advance our health system until it becomes a model worthy of emulation by other developing countries, with the result of gains. I am optimistic that the efforts of the government of Nigeria are tackling these issues through a multi-sectoral approach led by the Federal Minister of Health, with the collaborative efforts of relevant stakeholders, would improve the health indices in our nation and also foster economic prosperity of all Nigerians. I thank you for your kind attention.
Thank you very much, Honorable Minister. We really That was very informative to know what all the things that the government is doing, particularly around the brain drain environment, a more conducive environment for professionals to either stay back and work for Nigeria or at least to attract back those who are out there. I did note that not much was said about PAC. I'm hoping that during the interactive session, we can hear about the strategy for primary healthcare. As for the capital flights issue, I think that if we get to the need for tertiary care, so I'm really looking forward to the interactive session to hear your view on how you see investments in PAC translating into the solution for these two issues. Thank you very much, sir, for your contribution. Next on the agenda, we have Dr. Orekunrin, who is the MD CEO of Flying Doctors. Madam, we would love to hear from you. If you can switch on if your camera is not already on, please switch on your camera so you can put a face to the name. All right, so go ahead. Love to hear from you.
Good morning. All protocols observed. I know that there are a lot of very important stakeholders in the healthcare sector here, so I'd like to rest on existing protocols and in the interest of time, just go straight into my presentation. So I'm actually going to share my screen. Do you mind if I share it? Because I think that everything that I'm going to say is going to talk about or focus around the structure of the Nigerian population and where we are right now in terms of household earning. So I have a degree in medicine and surgery, and I'm just finishing my degree in finance and economic policy. So I continually think about the economics of how we're running our healthcare system, particularly with regard to how much people earn. So the Nigerian population by household, we have 2 million. Let me start with the millionaires, the people that earn above $1 million. We have about 12,000 of them. When you go to the people that earn $9,000 and above, we have about 2 million of them, and those are the upper middle class. Then when you go to the people that earn between $4,500 and $9,000, they're the skilled aspirational. We have about 8 million of them. Then when we go to the people that earn between $1,000 and $4,500, we have 65 million of them, and those are the survivors. They can just about afford a comfortable lifestyle, which means food and shelter, but they're surviving because they can't afford much else. And then we cross the poverty line and go into the ultra poor people that can't really even afford 3 square meals a day. And that's over half of our population. That's 112 million people that earn below $1,000 yearly. So those statistics are a combination of statistics from PricewaterhouseCoopers for the ultra poor to the skilled aspirational, then the upper middle class and the millionaire statistics come from McKinsey & Company 2017. And bear in mind that this was pre-COVID, when our economy was at least stronger than the post-COVID economy. So according to the World Bank, more people would have moved from that survivor class into the ultra poor class as a result of the economy. So when we're talking about brain drain, and just to talk about India, because we've been speaking about India a lot, this $9,000 and above class, that we only have 2 million in the whole of Nigeria, India actually has 100 million in this class. So of course you can build hospitals there and people have the ability to pay. In that millionaire class that we in Nigeria only have 12,000, in the city of Mumbai alone, where all of those great hospitals are, they have $60,000 millionaires. So it's a city full of ballers. When you go to New Delhi, they have $40,000 millionaires. When you go to Kolkata, which when you go there, it doesn't even look as fine as New Delhi, because I've been all over India. So when you go to Kolkata, they have about the same number as Nigeria. And Kolkata is the equivalent to Adeleke. basically. It's not even a tier 2 city, it's a tier 3 city. And they still have just about as many millionaires as Nigeria. So the fact is, we need to sort of put into context our own local context, because we keep on comparing ourselves to India. And I think that when we compare ourselves to India, we're really comparing ourselves to people that are not our mates. Even when it comes to extra rich people, Aliko Dangote is worth $6 billion. The Aliko of India, Mukesh, is worth almost $70 billion. So even on the billionaire level, we're not their mates. We are not mates in any way, whether the number. And the funny thing is that when you look at the ultra poor in India, they have less ultra poor. They only have 70 million ultra poor people in India. So they have far, far, far more rich people and also far fewer poor people. And as a percentage of their population, poor people make up 60% of our population. Poor people only make up 5% of their population. So no wonder they're able to afford healthcare. So that just on the side, like looking at our household income, and then now looking at, okay, brain drain and capital flight, how do we combat these issues? Looking at our local situation and not comparing ourselves to people that are not our mates in any way, shape, or form. So on brain drain, I think that one of the solutions, and it's going to be very controversial, but I think my job is to bring in new ideas and new ways of thinking and make, some suggestions that haven't been done before. I look at America and I look at the Americans in Nigeria. Do you know that as far as they carry that American passport, they still have to pay tax to America? Unless they want to relinquish the passport completely. And even relinquishing the passport is very, very expensive. So if you look at before the IPO of Facebook, a lot of their founders said that they don't want to be American anymore. They let them take a cheaper route so that they don't have to pay so much tax. But I realized that, as soon as Nigerians go abroad, they no longer owe anything to Nigeria. And I think that if you've trained a doctor and the doctor has paid 500K for 6 years, then maybe we should be thinking about them having a trade agreement with America, having a trade agreement with the UK to say, look, guys, we're not going to tax all of the people that hold our passports, but we want something remitted to us for our doctors. And Cuba has done this very successfully. So if you travel around the world, you see all these Cuban doctors, even in the most far-flung parts of Africa, you see Cuban doctors, they're not free. In fact, this year of COVID, Cuba made $16 billion from doctor exports. We only made about $4 million, $5 million from oil. So what are we talking about? If we know that what we are good at is exporting doctors, then why not try and monetize it like Cuba has done? We talk about agriculture all the time as if, we just have to improve our agricultural exports and we'll get more forex. Well, we've been doing this agriculture for a long time and we know we are not good at it. Otherwise, we would have been exporting by now. But one thing that I've noticed that Nigeria is very good at is exporting doctors. Our doctors, as much as we complain about our Nigerian healthcare system, we don't have businessmen abroad. My parents went to England and they tried to do business. The business did not work. We're not good. When we go abroad, we're not good at doing business, but we are good at doing professional services. That is our comparative advantage. You see doctors, salaried doctors winning awards for surgeries. So this should be something that we can, our ambassadors in those countries, but Nigerian ambassador to the UK, their Nigerian ambassador to America, these are the kind of things that we should say. Look, just like you people are paying Cuba, why don't you pay us? And it's better than collecting Naira tax, because Naira tax is, it's not going to stabilize our currency. One of the main reasons why you see all these devaluations is because we're not collecting enough forex. If we're collecting taxes from them, that tax comes in hard currency, balances off our currency. So I believe that healthcare, we shouldn't even be, the way that we beg and plead and say, oh, please allocate more money to healthcare. We're trying to make healthcare, attractive to other and competitive to other government stakeholders. But I feel like healthcare can actually be the savior of the Nigerian economy because we already are good at it. It's not something that needs an intervention fund to train doctors. We're already training doctors. They are already going abroad and they're all formally. So what we need to do is try and find a way to monetize it, just like Cuba did. $16 billion only on exports. It's not a joke. And I'm sure our doctors are just as smart as the Cuban doctors. So think on brain drain, that would be my point. If we can find a way to monetize it, and also, like the Honourable Minister said, task shifting is also very important. Because those ones cannot leave. I think she studied biomedical science, but they trained her to do basic surgeries for the NHS. This is not going anywhere because she can't be licensed in any other European country anyway. So I think also task shifting and making sure that we design our healthcare system in a way that we have our doctors, but tasks that don't necessarily need to be done by doctors. We have our people that can do them, and those people cannot leave anyway because they're not like from a recognized profession. So that way we keep our talents amongst us. We keep our talent in our country. So I think that that's very important, but that has already been mentioned. On the subject of capital flight, I think that the greatest, the number of dollars, in terms of the strain on the economy, we spend most of our dollars on food in Nigeria. The second amount of the second drain on our dollars is education. Actually, we spend quite a small amount of our healthcare of our dollars on healthcare. And it's usually for complex procedures. So the cardiology procedures, the nephrology procedures. So I feel that, when I work at the airport, so I've been in the air ambulance business for a long time. Out of the 200 million people in Nigeria, just about 1.2 million actually travel abroad at all for anything. And about 1 million, and about 1% of them go for medical tourism. So it's about between 10 and 20,000 people that go for medical tourism in the whole 200 million people. And they're going for very, very complex procedures. So as well as concentrate on the complex procedures, we cannot direct all of our healthcare policy for 200 million people for the needs of 10,000 people. I think also, like Dr. Nkem said, primary care is very important. And for a primary care consultation in Nigeria, it works. It's just that I have to pay. In fact, I don't go abroad for any medical procedure because if I go to the best hospitals, I can get good care. Only the ICU in those hospitals is like 1.2 per night. So if you're not financially fortified, then you cannot do it. There's a lot of medical tourism from America as well. When me and my husband went on our honeymoon, we went to LA and we're talking, I made the mistake of saying that I'm a doctor. I should have just kept quiet. So he started telling me about all his medical problems. And one thing that he told me is that he went to Mexico to go and fix his knee. And then I became very interested that you're in California, where the best hospitals in the world are. I had looked at Stanford University Teaching Hospital. They just spent $1.2 billion on one hospital. So I was like, why would you leave this wonderful place to the border of Mexico where you can easily get shot, where there are drug dealers? Like, why would you do that? And he told me that the healthcare in America is too expensive, that he went there and he got 10% of the price. So even the healthcare system for the very, very rich, we'll have to go abroad. So unless we design our healthcare system for these ultra poor and these survivors, which the only way to do cost effectively is to concentrate on primary care, you end up just with an American system. Still, as civilized as America is, what was the main election issue? They voted for the Democrats primarily because they want Medicare for all. They want free healthcare for all. They don't want it for some. Only certain people can access Mayo Clinic and all the best hospitals. The rest are in Mexico or going to India. So I think that we need to really look at this. That's why I put this diagram first. There are not 10,000 people that can go abroad. Nigerians don't even fly. We don't fly abroad. Only 1 million of us in a country of 200 million can afford to fly abroad every year. It's such a tiny number, but we put everything on that as if those people are the only people in Nigeria. So I think that's an issue. And I'm going to round up now with the issue of revenue. Because Nigeria, for us to be able to succeed as a nation, government needs to be able to collect more revenue. Whenever I speak to ordinary citizens, they say, the government is so, all the House of Rep, they are so terrible, the government people are so incompetent. Let me tell you something, that money makes people competent as well. The NHS budget $250 billion. I'm telling you, even if you give the most incompetent person $250 billion to spend on the healthcare system, they'll come out with something reasonable, especially if they only have 60 million people. Our revenues are so low. In terms of tax to GDP, we have the lowest in the world. We're only collecting 6% of GDP as tax. Whereas in Ghana, they're collecting 16%, 20% in Kenya as tax. In Europe, they're collecting 30% of GDP as tax. So when you collect the money, you can then spend it on things, but we don't even collect enough revenue to run a government. I wonder how the government is actually running on only 6% of GDP. Like I'm wondering how all the hospitals are still standing, how they're even able to do the little that they do. Because if our budget is around $25 billion, 50% on it, paying back the debt that we've already incurred and we need to service, and then we only have 30% left. And out of that 30%, 80% is spent on salary of civil servants. Then we only have so tiny, like a very, very tiny amount of revenue to so we need to bring our revenues up as well. So
Dr. Lam, I'm really enjoying your presentation.
So brain drain, capital flights, and importantly,
unfortunately, because we're trying to make this interactive, we don't have that much time left. So I can please ask you to just conclude so we can get to the last speaker before the interactive session. Thank you so much. Go ahead. Oh, I thought you were rounding up.
Yeah, I said brain drain, but monetizing our key staff, if not monetizing everybody, monetizing our key staff, number one. Capital flight, yes, it's important, but making sure that we're designing a healthcare system for the survivors and the ultra poor, as well as the skilled aspirational and the upper middle class. And then finally, making sure that we concentrate on revenues, because it's money that makes anybody look competent.
Very well said. I really, it's so, I like your presentation because it's practical. You know, what you were saying about exporting doctors as products, I think that was amazing. In Cuba though, their medical education is free. So the government does feel like the people owe them something. In Nigeria, medical education isn't free. But I'm sure it's subsidized in many ways. So I'm sure that we can make a case for that. So the Honorable Minister is listening, so I'm sure he's taking notes. Okay, so thank you so much for that. The next speaker, the last speaker that we have before the interactive session is Dr. Felix Ogedegbe, who is not here, I believe. And then we have Madam Bilqis instead. Is that?
I'm here. Hi.
You're actually here. Okay, sorry. So
yes,
we have
I've been here all the time.
We have two speakers left. Okay, so I apologize. Please, you only have 7 minutes. If you could please bear with us, we kind of run out of time. 7 minutes, and then we'll move on to Bilqis, who is also waiting to speak. Thank you very much.
Yeah, thank you very much. I hope you can all hear me very clearly. Yes. Okay. Thank you very much for this opportunity. Your Excellencies, ladies and gentlemen, I've been told I have only 7 minutes. You've got my slides on your side, so I don't know if somebody can share the slides, please. I don't know if you can share my slides. Moderator.
The slides will be shared shortly, sir. Thank you.
Thank you.
So you can go ahead and speak, and then your slides will catch up.
Yeah. Yes, I've actually enjoyed the conversation this morning, and I'm glad that we're now being able to talk about our problems and find a way to actually provide solutions and move forward. Because of course the dismal indices have already been discussed, and that's where we are. I think it will not be too out of place for me to say what we sow is what we reap. Where we are is on the basis of what we've actually put in. There's no other way to see it. What we sow is essentially what we read. Next slide, please. Yeah, so that's my agenda. I'm just going to do a quick introduction, levels of healthcare, why the flights, flight of funds from Nigeria, and then why the medical brain drain, and then we'll also look at what solutions. I'm mindful of the fact that I've got only 7 minutes to run through. Next, please. Right, so by way of introduction, I'm just saying every flight in capital without equivalent money coming into your country is a problem. So by the last speaker talked about, you know, there's evidence there's a lot of capital flight out of America, but there's also a lot of capital movement into America. So that's where we're supposed to be running a more modern economy, and so people ought to at the point where you actually sit on the control, be looking at what's going out and what is coming in reverse. What has happened in Nigeria is that a lot of monies have moved out of the country, and there's nothing, you know, to come back into Nigeria. As we speak, the pound is 600 naira. So when you're doing 600 of your own money to somebody else's money, you then understand that you're really, really in trouble. So we need to look at that. Capital flight itself is a direct response to value. If you don't create value locally, you're not going to get money coming in. So if you think about it, most of what we use, particularly in the healthcare space, most of what we use is imported. And I dare say it's not just in healthcare, in most other sectors as well. There's virtually no local manufacturing going on. There's no local value being created. And where you have a system and a situation where you have to run specialized services, from flying aeroplanes to providing healthcare to teaching in schools to books to things like that to food, and you're just trying to import everything, then you're going to find that you're not even bringing value at all. Healthcare is not an optional commodity, and I think we need to start to realize that. Unfortunately, we're in a situation where we're making too many babies, but we're not looking after them. We're making too many Nigerians. 30 years ago in this country, there was this very robust debate about how many kids a woman could have. And for some reason, nobody wanted to actually push that. Everybody had reasons not even talk about that anymore. And that just went, you know, was swept under the carpet. 30 years after, we're essentially reaping the seeds of what we have sown. So we're having too many kids, and we're having too many kids die. So that's why we're having the very high infant mortality. And we're still not at the point where we're discussing how we control our population. I think that is where we start. If you're going to give healthcare to the people in the country, you have to think of how to control the population. You think of how to control trans-border migration. If you don't think about this and start planning how to do healthcare, the primary person who receives healthcare is the individual, is the person, is the adult and the child in the country. And so when you find a situation where the number of health institutions we had 30 years ago compared to today haven't quite grown that much, but the population has grown exponentially, there's therefore no doubt that we will not be able to provide healthcare. And all of these indices that we're not quite happy with will be here. So brain drain, of course, we've said, is when people go around, when the indices are not right, when the environment to work is not right, people tend to vote with their feet. And once people have trained and they think that they can get better for the environments to work somewhere elsewhere, they will go. And let's face it, let's be very, very clear about this point. It's not only doctors that are going abroad. All categories of workers are going abroad. Even cleaners go abroad. Nigerians are going abroad to do all sorts of jobs and roles. So we're losing everybody, and we're losing everybody without any real evidence or ability to attract people back. So I think we're now at this point where we need to start to think of how to turn things around. It's not good right now when you practice in this country. I saw Ola's last slide, and the truth is that most of the people who come to face you in the clinics are poor, and you're looking at wondering what's the plan for healthcare for them. So somebody asked me in the UK and said, "What do you mean you can't look after people because they can't pay? How do you tell somebody to walk away because they don't have money?" I said, "Well, that's what we do every day. We tell people to walk away because they don't have money, and that's what's going on. And we have to find a way to reverse that, because that is not the way healthcare should be given to people at all." Next slide, please. This is the simplest slide I have put here, because I think this is where a lot of things actually get mixed up and lost. Levels of healthcare: primary, secondary, tertiary, emergency medical services. To start with, first of all, we have virtually not even talked about number 4. The emergency medical services is so key, and Nigeria had virtually no coordinated emergency medical services. Any country you go today, these are the levels you find, but people think it's 1, 2, 3 only. Secondly, when people think of, and I've heard on this forum as well, when you think of primary healthcare, people are talking of government primary healthcare centers. They're not the same. And we need to start understanding that, because for each of these levels, private and government players come in. And government healthcare centers and primary healthcare are not the same. We need to, if we start to actually structure our primary healthcare services to be essential primary healthcare services, we understand. Therefore, for instance, the private hospital that a lot of us go when they have fever, when they have malaria, things like that, that's your primary healthcare. And we need to kind of stratify our healthcare properly. If you live in Abuja, for instance, and you know about the National Hospital, you find that many government people go to National Hospital when they have primary healthcare needs. And you cannot use tertiary healthcare services to render primary healthcare. So some of the failures we have as a country, it's not because of lack of resources. It's lack of, people actually having to sit down and plan care. We're not planning care, and we want care to just come in. You see, I used to work in the UK, and hours of thoughts are given to healthcare, how to plan it, not just the resources. So I don't even think if you give 15% of the national budget to healthcare that things will work. Things won't work, because we need to do a lot of planning. Primary healthcare means that if you sit in a national hospital, a tertiary center, for instance, it's on record that 65% of the resources in the tertiary hospitals are being used to treat primary healthcare problems. Which country does that? Nobody does that and succeeds. If you do that, you're going to reap bad results. So I think we need to really look at that again. I'm almost done. I can show you. And stratify. Yeah, I'll be done. 2 minutes.
We haven't.
Sorry? 2 minutes more and I'll be done. Next slide, please. So again, I don't actually think I have the time to now go through all of these, but these indices we already know that how many Nigerian doctors work in the UK and all of that. And I've said it's not just the doctors, pharmacists, cleaners, everybody's going. Nurses are all abroad, because we haven't actually created a model that will work. And next slide, please. Next slide, please. Thank you. If we need to tackle this problem, we need to start planning our healthcare again. I agree that we need a healthcare bank. I agree that we need some form of healthcare, real sit-down planning mechanisms. I think that we need to, yes, India is a very good model, but like has already been mentioned, the amount of planning they've put into and the indices that they are very, very far from us. I think we need to do some form of healthcare re-engineering in our country. It's sad that we quote indices of how many patients to a doctor in Nigeria. Doctors at every level have no jobs. Housemanship, you will not find placements. Residency, you will not find placements. You come in as a consultant. So let us remember here that one other reason why people go abroad is that they have no jobs in Nigeria. And if they have no jobs in Nigeria with the very poor healthcare indices, it then means we have a fundamental lack of planning. Next slide, please. For the private sector, I would say, and this is where I play, we can make Nigeria a tourism destination as well. So in addition to other ways or means of trying to raise resources for our country and expand the fiscal space, Nigeria can become a private destination. But For that to happen, we need to tackle security problems. So all of these problems actually interrelate. You cannot have a very unsecure place and then people will come for healthcare. For that to happen, some policies have to be friendly. For that to happen, for what I said about stratification of healthcare, primary, secondary, tertiary, emergency medical services, that has to be in the law. That has to be streamlined. For that to happen, we need to look at the Constitution again and see what it says about healthcare. For that to happen, we have to have improved research, and people have to trust the system in general. Right now, people don't trust our systems. Lastly, for that to happen, for people to start to come to Nigeria for healthcare, there has to be regulation. The healthcare space in Nigeria, in terms of how you practice, is one of the most unregulated spaces in the world. Anybody can hire a flat and do anything, and that's not changing with time. For healthcare, for Nigeria to become a tourist destination for healthcare, there has to be a deliberate effort to put in regulation into our healthcare space. I think I'll stop here. Thank you very much.
All right, thank you for that presentation, Dr. Felix. I think we've lost Dr. Nkem for a bit, so I'll hand over to Dr. Chioma to take over. She's the co-moderator.
Thank you.
Okay, over to you. Over to you, Dr. Bilqis. All right.
Thank you very much for having me. The Chairman, Joint House Committee on Health Institution and Media Publicity Affairs, Honorable Pascal Obi and Benjamin Kalu, the Honorable Minister of State for Health, the CEO of Cedarcrest and Flying Doctors, founder Smile With Me Foundation, distinguished ladies and gentlemen. It gives me great delight to be speaking on capital flight and brain drain at this very moment of our nation's development. Capital flights in health sector is described as a large-scale exodus of financial assets and capital from Nigeria due to political or economic instability, currency devaluation, and even imposition of capital control. While brain drain, on the other hand, is a migration of highly skilled, qualified healthcare personnel from a country. You all will agree with me that these all fit in the Nigerian context today. And for a country like ours, which is a low-medium income country, this has far-reaching effects on the general population, and improvement is a mitigation to improvement of our nation's healthcare indices. We have identified certain factors that have increased over the last decade capital flights and brain drain. And one is training of healthcare personnel. A resident doctor in Nigeria, can qualify and take a minimum of 3 to 5 years to have a slot for residency after passing his primary examination in respective faculty. While the same doctor migrating to the United Kingdom can get into residency within 4 months of getting there on merit. What is the solution? We need to find a way to get every specialized doctor who is interested in training, who have passed the requisite exam, to get automatic employment in the various training institutions within the country. It means that we should ensure the sustained implementation of the Medical Residency Training Act. We need to increase remuneration and have additional allowances for doctors and other healthcare workers. This serves as a means of enticement and keeping them so we can retain our qualified healthcare personnel. The issue of taxation too, which is essential to all essential workers, particularly call duty allowance, has also further declined the income of doctors and other healthcare workers. It therefore means that if the legislative arm have a cursory look in taxation of call duty allowance for doctors and other healthcare workers, it will go as an incentive to improve the morale of this category of workers.
We need to have centers of excellence in Nigeria. Having centers of excellence for various specialties such as cardiac, renal, neurosurgical, cardiothoracic, oncology, and even trauma will go a very long way in creating more spaces for training of resident doctors, employment of the post-fellowship doctors, and keeping them within the country for us. These centers should be independent of the currently existing tertiary healthcare institution. The essence of this is to make access possible for people who are in need of highly specialized care. And this should be spread across each geopolitical region. We are also requesting for access to universal health coverage. We're requesting for the National Health Insurance Scheme to be made available and accessible to every Nigerian, whether in the public or in the private sector. With these highly specialized centers of excellence, you will agree with me, and with the increase in access to health insurance, it will be easier for Nigerians to access health care and also the professionals that is required for such. This will mitigate the challenges that doctors face on a daily practice when they get frustrated from managing patients who cannot afford healthcare bill. Interprofessional disharmony. A clear job description will go a long way, and this should be done in line with global best practices. We need global best practices on remuneration, on multidisciplinary team meetings, should be encouraged also for highly specialized patient care, so that patients who are coming to seek care can be very well assured that they are getting same care they would have gotten if they had gone outside of Nigeria. We also need to design special fellowship program for returnee doctors who, out of patriotism, will want to return back to the country to give their expertise in service to Nigerians. This will encourage very experienced foreign doctors who are unsure of where they will fit in when they return back to Nigeria. Lastly, Nigeria currently trains an average of 1,500 doctors on a yearly basis in various specialties. But what happens? This quantity of doctors who become specialists, fellows of the various postgraduate colleges, some winning prizes at the end of that exam, do not have job security. What it means after passing the exam is that within 6 months, you're automatically flushed out of the system. This sense of job insecurity has worsened brain drain and exodus of our healthcare professionals. We're requesting that the federal government has a way to create job opportunities for consultants, cadre, specialist doctors at the time of finishing fellowship. That way there is job security, and we can achieve this by making doctors who are already in residency training have job security. While the residency is tenured, they can seamlessly transit with the cadre that is appropriate for them into the civil service within the country without them having to go looking for jobs. This will not just keep the doctors within the country, but will improve the healthcare indices of the country. Thank you very much. Thank you so much. Thank you so much, Bilqis. I mean, that is definitely from the resident standpoint about training and about how to, ensure that we're somehow benefiting from all the expertise that is being accrued outside the country. In the interest of time, we're going to move directly to the questions that have been put together by the participants. This is supposed to be an interactive session. So I know that the ACE Center has been collecting questions, and I'm going to hand over to my co-facilitator, Dr. Chioma Mohammad, to handle this section of the program. Thank you very much.
Thank you so much, Dr. Nkem. Thank you so much for having held this down. It's been a very engaging conversation, as I said earlier. And I particularly like the fact that we have the major stakeholders gathered here. We have our honorables from the Federal House of Representatives. We have representatives from the Ministry of Health. And we also have, major stakeholders from the associations, health associations. We have quite a good number of questions, I must say, a lot of them. I told someone earlier today that this is going to be a very interesting conversation because it affects doctors and everybody in the healthcare sector. I dare say it doesn't just affect the doctors, but everyone in the healthcare space. And this is going to take me to the very first question for not just for the House, not just for Honorable Martins, okay, but also for the Honorable Minister of State for Health. So this question goes this way. It says, what is the National Assembly and the Ministry of Health doing to ensure that Nigeria's health sector competes favorably with other countries? So a lot has been mentioned. To give context to this question, a lot has been mentioned. And Honorable Martins, I love the fact that you started with your personal story. You showed that you already feel the pain of the people. So we want to know, what are the actionable steps? You know, you mentioned particularly poor job satisfaction, and that has been repeated by other panelists. So we want to know, what are the actionable steps that are being taken to make sure that the healthcare workers in Nigeria are satisfied with their work? I'll give instance to the hazard fees, for example, life insurance, health insurance for healthcare workers, and of course, remuneration too for the healthcare workers. We want to know the actionable steps being taken.
Thank you so much, Chioma, for this. I think the Assembly, from the Ninth Assembly, Mr. Speaker, as a person, has been particularly interested in the health sector of this country. When we came in the Ninth Assembly, his main step, even before COVID-19 came up, his main step, what do we do to have industrial harmony? So when the resident doctors were having problems, he personally intervened, and he had to have some level of collaboration with the Ministry of Health. Senator Mamora was equally involved with the Honorable Minister of Health, and they tried everything to ensure that they resolve the problem with the resident doctors. So it is the common interest of the House is, first of all, that you have to have harmony, you have to have peace within the industry. Then two, that you have to bring out some legislative instruments that support the aspiration of government on what to do to strengthen healthcare in the country. And some of these legislative instruments are some of the things that I've tried to present in the papers that we've done, that during appropriation, what do we do to increase the money provided for the health sector in the country? What do we do to fall in line with the aspiration of government that if we say that we want to work on the primary health sector, the primary health sectors in Nigeria, that is the way to go? Then there must be some consequential provisions in the budget of the country, national budget, to ensure that we create more primary health centers in the country and make them functional. It's not just creating them, but making them functional. That if you say that you have problems, like what we have said, what the last presenter talked about doctors, that when you have doctors in the country, that you see people graduate in the residency program, we have done the Residency Act, but now have to make it functional. And that when people complete their program, most of them, while they leave the country, some of people leave the country and further working in the health sector, is that they don't get employed. There is no seamless transition from being a resident into being a part of the workforce in Nigeria. By the time they stay for a few months, they go. So what we are doing within the health institution is to settle down, meet with those running the health. We have three main committees in the House. We have the Committee on Healthcare Services, which is in charge of the primary healthcare center. We have the Committee on the Health Institutions. Then we have a committee we call ATM, which is in charge of tuberculosis, malaria, and AIDS. I'm simply surprised that they were not invited in this discussion. But these three committees come together, and we'll be working with the heads of the various institutions to get their input, the different associations in the health sector, to make sure that we get organized and link up with the aspiration of the Ministry of Health, to support the Ministry of Health, to bring our own input in terms of legislation to support what the people are doing there in the Ministry of Health. And I think by the time Mamora finishes, because he has been on the two sides, and he's now the Minister of State for it, and he has participated in all the interventions and all the presentations they have done to the National Assembly. He's in a better position to talk more on the policies of government with respect to what they're trying to do to strengthen the health sector in the country. Thank you.
Thank you very much for that.
Yeah.
That takes me to the Minister of State for Health. Honorable, are you here, sir? He rightly mentioned that you're on both sides now. You represent both the health sector and the government. So that's very helpful to us in this conversation, because I think you're going to be our eyes and our mouths too. So this next question, when you were making your presentation, you mentioned something about, Nigeria training doctors and, exporting doctors in quote, who were indigenously trained here in Nigeria. And, I could feel from, it could be my own understanding, but I could feel, the pain in your voice. It felt like we trained these people and everybody's coming to take them from us, So we want to really know if this is really the pain of the government. What are the actionable things that the government is doing? What are the significant strides that you mentioned? You mentioned that there are significant strides being taken by the Ministry of Health. What are these significant strides? Because I think the problem with the people, because I represent the people at this point, so the problem is that we are not seeing what is being said is being done. We want to know, how can we be able to track these things that are being done? Where are they available? What is being done and where can we see them? I don't know if you got my questions. And so we'd like to know, what are the significant strides that are being made by the government to make sure that, we retain the indigenously trained doctors? Thank you.
Yes, thank you very much, Chioma. I want to thank my friend, Honorable Martins, and all the participants on this platform. Let me assure you that I have also gained a lot on this platform, and I'm honored to have been invited, because, education, learning, is continuous. So now, yes, Chairman, well, I cannot be on the two sides at the same time. Yes, my background is in the legislature, both at the state and at the national level. Now I'm in the executive. But I want to agree with my brother and friend, Honorable Martins, that yes, some measures have been put in place, but the whole thing starts from the issue of, I want to commend, I think, Dr. Orekunrin, how much, she said, we must concentrate on revenue. Revenue, I'm not saying money will necessarily solve the problem, but the truth is we need it. The entire budget of the whole country, the whole country, Nigeria, is not up to the budget of California. It's not entire. So what really can you achieve with that kind of situation? These are realities. And we just must take it from the first step. And I had Orekunrin say that Nigeria has the lowest tax to GDP ratio in the whole world. I mean, these are fundamental issues that we need to come to terms with before we can even start to talk about any other thing. Now, having said that, well, but because we can't just continue to complain, but within the ambit of what the realities are, maybe for the first time now, thanks to COVID, if I may say that, Nigeria would definitely come out better of COVID, because the COVID has helped the entire country to appreciate that we are in a mess in terms of our health sector. But attention, thanks to all the support we've got from home and abroad, COVID and all others like that, who have now given a lot of attention to the health sector. We need to fix our infrastructures, health infrastructures. We need to upgrade, and we are paying attention to that. We are upgrading now. There are a lot of states that ordinarily will probably not have isolation centers and even ICUs and all that. But this coming on board, even at the federal tertiary institutions as well, health institutions. So we are upgrading, we are equipping, so that we can create conducive environment even for the health workers themselves, whether they are doctors, they are pharmacists, they are nurses. The environment in which they work has to be what they want, what they expect. The facilities must be available. That's why we have PPP projects now in so many centers, in Luth, the Kano, Umar here, some of these, which are projects, PPP projects from sovereign wealth investment. So we are improving especially the diagnostics. The diagnostics are key, because I always say that you cannot treat what you don't know. The most important aspect of patient management, as far as I'm concerned, is making accurate diagnosis. So that's why the diagnoses are important. You must be able to make diagnosis for you to know what you want to treat. So that is in place. Of course, we are working with the relevant agencies, the Office of the Head of Service, Salaries and Wages Commission, so that we can, issues of remuneration for health workers will be appropriately addressed. And of course, issues of career projection. The health sector is not standalone when it comes to addressing some of these issues. We have to do this in collaboration with the Finance Ministry, with the Office of the Head of Service, with the Salaries and Wages Commission, and all that. And of course, the National Assembly that has to put in place the necessary regulatory, necessary legislative framework to achieve some of these things. So we are. Then, of course, we also need to look at ourselves, what I call the issues of attitude. Attitude. And good enough, we passed a policy recently at the Federal Executive Council, the policy we call national moral orientation and all that. Because it's important. A cleaner will be working as if he's doing you a favor. There is no dignity of labor. People will be working as if they are doing you a favor, because that dignity of labor is not there, and it cuts across. These are essential things that we must put in place. So we need it. If I say we need national rebirth, we need it. It's national rebirth. So because it's always easier to point the accusing fingers. When people say government, right? Government does not exist in a vacuum. It's people that make up government, including you and I. So these are fundamentals that I believe we need to address, and we need to look at ourselves. That's why the popular thing that change begins with me. as individuals, then collectively we can move ahead. So I think these are some of the things that I want to say. Well, I don't know whether I should say at this stage, because the issue of primary health was, I don't know whether you want me to comment about that right now, or you want me to...
we'll still come right back to you. I mean, okay. There's still some questions. I want to say thank you so much for that. Just to weigh in a little bit, I think, yes, it's very, very important as individuals that we work on ourselves, but that still brings us back to the key issue that's been repeatedly mentioned during the different panel sessions, and that has to do with job satisfaction, because we can't actually just hold someone, by their neck and say, hey, be happy about your job, when they've been owed for, months, or owed for a couple of months, So while that is happening, I think it's something that should happen hand in hand. So the government plays their own role, the people also work on themselves, Thank you so much for that, Honorable Minister. I'm going to direct my next question to Professor Innocent, which I don't know if he's here with us, the enemy president. So are you here? So if you're here, there's a question here for you. It says, you mentioned a bank for the health sector, and we would like to know, how would you recommend the government structure the bank, and what will be the bank's key mandate? And another question for you would also be, you mentioned the CBN, I think that was the CBN 100 billion intervention. So can we get to know more about this, and what are the specific issues that you are having with access? You mentioned that the health care stakeholders can't access it. So, I mean, the government, we have the House of Representatives here represented well. We have the Ministry of Health here. So we'd like you to table what exactly have been the hitches you've encountered in accessing these funds, and also about the bank you mentioned, what would you want the government to do specifically? How would you want this to run? That's the bank's key mandate. Thank you. Okay, I don't know if he's here. Okay, he's here. Sir, I don't know if you heard my question. Professor Innocent.
Okay, I think we should we could redirect that question to anybody who is interested in answering. Okay, he's with us.
Is he here?
Yes, I am.
Okay, welcome back.
I am.
So, do I repeat the question, or did you get the question, sir? Hello, sir.
Hello.
Yeah, I wanted to know if I should repeat the question, or if you got the question. Okay, I think he might be having network issues, right? So I might just have to go over to the next. Panelist. Then whenever you are ready, we'll take that question. So I'm going to direct my next question to Dr. Ola. That was a very powerful presentation, and I like the fact that you were very, very specific, with your recommendations, and you were right. In fact, you were thinking outside the box. That's even if the box exists. No, I had ever thought about that. So you mentioned the case with Cuba, and you also made recommendations, which I'm very sure the members of the House of Representatives have also heard. I'd like to know about the taxing of these other countries. People are asking questions. They want to know, who exactly do you recommend will be taxed? The doctors or the country? So I don't know if that's clear. So you mentioned taxing the doctors, people outside, the doctors who travel, or even healthcare workers. So will it be the doctors? Because I know that they are also being taxed in those countries. So are we saying extra tax for them, or are we relating directly with the government? And also, do you think that if we in an ideal situation, we are able to really do this and we have the funds that we need, do you think really that it's the funds that constitute the bulk of our problem as a nation, the fact that we don't have enough funding? Because there was something Dr. Felix mentioned that I agree with, that money is not really so much of the issue. We still have a structural problem. So when we get these funds, the accountability, disbursing these funds and accountability, how do we properly make sure that it's accountable? Is accounted for?
Understood. So first, I'll just touch on the healthcare bank quickly. I think a lot of my colleagues think I was evil because while they were all doing masters in orthopedics and cardiology, I carried my head. I went to go and do a master's in finance. But it's helped me to be able to contextualize a bit better, the relationship between finance and healthcare. And I think, some of the issues around a potential healthcare bank and even the CBN funds is it concentrates on one type of funding, which is collateralized debts. And a lot of people in the business of healthcare don't have collaterals. It doesn't look at the other types of debt that could be extended in the healthcare industry. So equity funding, which I do, I've equity funded now about 15 healthcare companies. And equity funding is more than money. It's about the mentorship, it's about the relationships, and you're a stakeholder, you sit on the board. So I sit on the board of companies from manufacturing to retail pharmacy to diagnostics. So we should also look at how to extend equity finance and uncollateralized debt, venture finance, project finance. And these are all different types of finance that I don't have sort of the time to go into because that wasn't the question that you asked me. But for a healthcare bank or a healthcare financing company to be more robust, then there need to be other factors looked into and different types of finance for different types of structures, especially hospitals. I mean, the return on investment for hospitals is over 10 years. And even though the CBN intervention fund is long-term, it's collateralized debts. That means that you have to bring collateral of whatever you are borrowing. And that makes it quite difficult for people that don't have the collateral. And a lot of healthcare entrepreneurs don't have that. So we should look at other types of finance. For the revenue issue, Nigeria does have a revenue problem. And I think that, we tend to shy away from it and we tend to, not want to talk about it. But I think that if you look at Nigeria in terms of a tax take compared to even other, countries that we would consider smaller countries like Ghana and Kenya, you can see that they take a lot more tax than us and can do a lot more social services from that tax. And it's not just about money, it's about structure as well. But the UK budget for 60 million people, the system that we're comparing Nigeria to, the system that we want Nigeria to be like, spends $250 billion per year on tax. Our federal budget, on health, $250 billion per year on health. Our federal budget is about $1 billion. That means that if Boris Johnson came to Nigeria today and said, you know what, I love you guys. You Nigerians are so happy and I just want to give you all of our budget. It would take us for almost 300 years, healthcare. So it's not purely a revenue problem, but there is a revenue problem incorporated into it. The fact that we have 200 million people and we have a population that is growing at 4%, and we have our revenue or our economic growth, which is growing negatively, means that every single person is getting poorer. And this getting poorer has not started now. Nigeria is actually one of the only countries in the world where on a per capita basis, people have been getting poorer for the past 20 years. Now, this might be, this is partially due to government. It's partially due to government policies. It's partially due to, management of government. But it's also due to, us not looking at our comparative advantage and saying, what are Nigerians really, really, really good at? And I think that if we look at what we're good at, then it might not be the same as what other countries are good at. Indians the Indians' economic growth was not produced by the Indian government. It was produced by actual Indians realizing that they're good at producing software, they're good at manufacturing. This might not be. I think that Nigerians are very good at services. We're good at doctoring. Even the ones abroad in the so-called enabling environment, they're not starting companies. They're doing work. They're bankers, they're doctors. They're very, very good at salaried professions. So if that's what we're good at, then I feel like we should direct some of our effort towards that. And the way that the Cubans do it is that they take a very small percentage of their salary. So it is double taxation. But the Americans here also are paying double tax, and they're paying it happily to the IRS. And the IRS, even if you're in Congo, in the forest, they'll find you. If you're American and you have that passport, they will clamp down on you. So I feel like if we really want to grow, we need to find a way of exporting what we're good at and find a way of doing that innovatively. And this is just a suggestion. And I'm not saying that we should tax the government, but we should find a way of working collaboratively with these countries to extract some of that back into our healthcare system, because our tax revenues are so low. And like the last diagram that I put up, you know, the survivors, people that are barely surviving, kind of make up a huge percentage of our population. As unequal as Nigeria feels, even our billionaires are not rich. We're all kind of like, you know, not that rich. So if we want to really grow our economy, we have to think about how to generate more revenue. And we're not going to do that the same way as other countries do that. We have to look at this graph and think of what is the most innovative way right now that we can get revenue today to grow this economy. And the most important form of revenue is not Naira revenue, it's dollar revenue. We want ways that we can get foreign currency in. Thank you.
Yeah, well, thank you so much. Thank you so much for that. And I dare say that these can happen hand in hand. You know, while we're focusing on the revenue aspect, we're also fixing the already identified issues that have been mentioned by our panelists. We'll have one more question for Dr. Felix Ogedegbe. You mentioned during your presentation quite very, very wonderful presentation. And there was something that you mentioned, and you weren't the first to mention that. That was population control. Specifically, I think the way you even explained it, it hit my heart. You know, you said our population is increasing, and then, you know, our revenue, our economy is decreasing. It's like the only thing that is moving forward about Nigeria is the number of people, you know, being brought in. And until we are able to really address that key issue of population, you know, we can't really make progress. So I'd like to know, and this is in concurrence with the question that is here, you know, I'd like to know what are the measures that you propose that can be put in place, you know, talking about population control, so that, you know, people, I'm sure some people's brains will already be going, population control. What is it talking about? You know, so what are the measures that you think? Then secondly, you mentioned that some of the things, you said that Nigeria can be the tourist attraction for medicine or for healthcare, you know, if we put the right things in place. And you mentioned security, friendly policies, tackling corruption, and improved medical research. So on the part of friendly policies, what kind of policies are you talking about specifically that you think are not favorable for the private and public health sector as regards healthcare in Nigeria? Thank you.
Yeah, thank you very much. So on the population control thing, so I'm not an expert in population control by any stretch of imagination, but we've got to be realistic here. A country is about looking after people. It's a defined geographical space, and you've got a defined number of people. If you don't look at how that population grows, then you're not even going to start. And most other countries that we are actually trying to mirror after, this is one of the things that they talked about very early when they were now trying to re-energize themselves for growth. And if you remember, I did say in this country 30 years ago, when I think that was during the tenure of President Ibrahim Babangida, population issues and how many children a woman should have another was hotly debated in this country. So if you don't debate such things, and that's what I'm glad that this is being arranged by the National Assembly. These are the things that they should talk about. if you don't talk about population control, you don't talk about cross-border migration, whatever you then put down as healthcare for your people will be filtered away. You're not going to get any results at all, because X number of people can just cross the border and take what you've already planned for your people. Or as more people are being born, you don't even have results from that. So I don't have immediate answers to that, but I know that if we don't think seriously about population control and plan for the next 10 years, then we're not even going to start at all. In terms of health tourism, I mean, the Indians didn't do much. They didn't do too much, really. Well, not to say they didn't do much, they did a lot. But there are basic things that you need to do. All of the people, if you take India, for instance, all of the people who go out of this country seeking healthcare in India do not go to the Indian government hospitals. So there are various models to pick. But when India thought that health tourism was going to bring money to their country, one of the things they did, they didn't privatize the government hospitals. They didn't do that. They gave incentives to private healthcare players, and gave them incentives, encouraged them, and people actually came back to India and set up firms and set up big hospitals. So you have tax breaks, you have incentives, you have all sorts of things that actually ensure that people are encouraged to come back and set up hospitals, such that they then know that the government is actually looking at the revenue that they will make from foreigners coming into India for healthcare. And the relationship between the rupee and the dollar is not too far from the relationship between the naira and the dollar. When your currency is weak, it's also an advantage because the cost of manpower in your country is low. So $1 coming into Nigeria is going to achieve a lot. And so because of our regional status in West Africa, the problems that you're having in healthcare in Nigeria are not alien to the rest of the region. Most countries in the region are suffering the same. Francophone West African countries have traditionally sought healthcare in France. And now they have a lot of difficulty doing that. In our practice, we get a lot of inquiries about people wanting to come to Nigeria for healthcare. And they will come, and some have even come already. So when government then creates a definite strategy to push this, to say, well, we want people to start to come into Nigeria, we want to make sure they have a good experience when they come. From a security point of view, from an ease of getting visas point of view, so you get incentives for medical visas and things like that. This is a sector that can be looked at, and this can actually bring a lot of resources to Nigeria.
Okay, thank you so much, Dr. Felix. Thank you so much to everyone. I think to just wrap this up, I think a food for thought I would leave for everyone here would be, we've mentioned the deplorable state of the healthcare system, which is very obvious, and then the ratio of 1 is to 2,753 patients. That's one doctor is to 2,753 patients, which actually mocks the WHO recommendation of 1 is to 600 patients. I think that should be looked into. And talking about doctors coming back, the Minister of State for Health mentioned doctors, periodical return of doctors in diaspora to come and train our doctors and all. I think that is very, very important and very necessary. But as we also do that, we should consider that we should ask ourselves the question, what have we given to these people that we expect so much from them? Then to give us time to really reassess the situation, on ground and look for measures. Because while these doctors are looking seemingly scarce, we still have doctors here who do not have jobs. And I wish the NMA president was here to let us know what exactly is being done. I know a couple of doctors who are still unemployed. Why? And why are we complaining that there are no doctors when some of them who are here are not employed? So I think that should be a food for thought for everyone here present. So thank you so much. I'm going to hand over to Barrister Obina from the ACE Center to wrap this whole session up. We still have another session coming up, so thank you.
Can I just say something before you?
Yes.
Do your wrap up?
Yes, please.
Right. Well, thank you. I want to say thank you to everyone on the platform. I deliberately, I was bill to go somewhere, but I thought this is very important. Now, from my legislative background, let me say this, that for everyone out there, the most important role of a legislator is representation. Now, people out there must appreciate that they have elected people to be in the legislature to represent them. And you cannot have effective and efficient representation, effective and efficient lawmaking without good representation. So there are issues. One of the things I have observed in our system, in our country, is that we shy away from wanting to discuss certain issues. The issue of population control mentioned, which is critical. Essentially, why we are not discussing some of these things is because of religious and cultural beliefs. These are the reasons why we are not discussing these things. And for me, you cannot attempt to mop the floor when the tap is still on. You must turn off the tap first before you start mopping the floor. So I'm saying that when there are issues, people can approach their representatives in the National Assembly and they request for these issues to come up for discussion. Public hearing or whatever, town hall meeting, and there are so many fora for pushing issues. Very important to say this. Well, let me just allow you to go. I just thought that is important for me to say at this point.
Thank you, Honorable Minister. This has been very enlightening. In fact, the whole idea of this interaction is to, one, maintain a constant channel of engagement and feedback between the House and the people, especially the sectors, the various sectors of the economy. And we are really grateful to Honorable Benjamin Carlo and the committee on his Committee of Media and Public Affairs for this. This has been really productive. I can assure that there has been a lot of actionable outcomes or points to work on. Of course, from sessions we had yesterday, one key thing that has been recurring is the importance or the need for PPPs as an innovative or creative way to improve healthcare funding and financing, and that's something that will be looked into. There was also the need to Dr. Ola really, was really thinking outside the box, and she brought very innovative, very challenging and bold ideas, especially the one of monetizing our exports. That is really something to think about. I can't thank you for that, actually. That's really something to think about. That's something that our organization will also be highlighting in our recommendations to the committee, the public affairs committees and the committees on health institutions and health services. There is also the recommendation of population control. That's something that it's also testy that we should look into. And then I like what was mentioned by Dr. Felix, that the government should look into ways to incentivize medical tourism in Nigeria. I mean, Africa is worth over $40 billion. The healthcare industry in Africa is worth over $40 billion. And there's no reason why while we're looking at improving our own healthcare system, we shouldn't look at making ourselves a tourist hub. A medical tourist hub in Africa, at least. So that's something that should be looked into. I really want to extend my gratitude to the minister, the members of the House who have participated, the chairman of the Committee on Health Institutions, represented by Honorable Martins. I want to really thank the Committee on Media and Public Affairs for this opportunity. We really appreciate it. And every other person who has participated. And to the participants, there were so many questions. We couldn't take all of them because of the time, but I can assure you that these questions are going to be addressed in time. This is just the beginning. This is just the first step in a series of ongoing interactions between the health sector and the House of Representatives. So I can assure you that your questions will be addressed, your feedbacks will be addressed in time. The National Health Bank for Health, as propositioned by Professor Innocent Ujah, that is food for thought. That's something that we'll be looking into, especially in our recommendations for bills to be implemented. In fact, Honorable Benjamin Kala, I noticed where he acknowledged that in the comment section and said that that's something that the House will look into. So we are very happy that the House is already looking into acting on some of the recommendations here today. So I won't take much of our time. I just want to announce to our participants that the next session will begin in less than 2 hours. We'll be discussing the subject of universal coverage in the context of the national health insurance and tax-based financing. And so I want everybody to come and join in, and let's hear your opinions. Thank you so much to everybody, and we'll adjourn till 2 o'clock. Thank you so much.